Sometimes the tool is not important, but it's the knowledge of the phenomenon that is important.
So excited you're tuning into Medical Experts in Football. I'm Tawa Deshubin, your host. So today's guest is an Italian sports medicine physician, and let me tell you, his passion took him from being the child helper of the helper of the helper, pretty much the bottom of the totem pole, to now leading the head of the Education and Research Department at the Isokinetic Medical Group. He's a clinician and researcher whose area of study is on movement analysis and knee injuries, especially ACL injuries, which we'll get to. Hang tight as we discuss considerations when it comes to movement analysis testing, implementation of research into practice, and special considerations when working with athletes. And here's Dr. Francesco Della Villa. Your surname, what city does that originate from? Or is it Italian?
Surname is South Italian surname because my father family, my grandfather family came from the south of Italy. And Della Villa, when you have a composed surname, so you have two nomes, this is generally South Italy. And Della Villa means from the villa, villa, like an house, a beautiful house.
That brings me to the point. What city did you grow up in? Was it Bologna or is a different city?
I grew up in Bologna. Yes.
Oh, Bologna. That's a city in northern Italy, right? And it's a larger city, but it's not as common as, say, Rome. Why is that?
No. Bologna is in the middle of the north, and is not so commonly visited by US people. Mm-hmm. But we have a lot of US tourists, but mainly you go in Florence, Venice, Rome. These are the big three. Mm-hmm. But Bologna is an historical city, a medieval city, and it is also a university city because we host the oldest university in the Western world. Mm-hmm. So it's really a rich city in terms of culture.
Yeah. Well, if someone were to visit, I know you said it's a rich city in terms of culture. What is one place that you enjoyed going to as a child that you would tell them to go?
For sure, up to the hills, because Bologna is nearby. Bologna, there are the hills. So if you are familiar with LA, with Los Angeles, you know that mm-hmm. you have the harbor and then you have the hills. And at north, you have all the hills. And then you have the valleys. And Bologna is exactly like that. So you have a flat land, but then the hills. And then mm-hmm. the top of the hills, there is a church called the San Luca. And this church is really wonderful. So there is an hike that you can do, and underneath the portici. The portici are the covered streets that are typical from Bologna, because in Bologna it's pretty rainy, and so we used in the past to build these structures really to cover people that were walking. And mm-hmm. there is this walk that starts from one of the doors of the city center, because city center was medieval, no? So it was there were walls all around the city centers mm-hmm. with a number of doors. I don't remember if it is 9 or 10. One of the doors is called Porta Saragozza. So you start from Porta Saragozza and you go up in this portico, very famous portico, San Luca portico, up to the hill until the church. This is a very special place to visit, and also a good hike or run. It is 3-4 kilometers. I used to do it.
Well, cool. Well, I'm going to be going to Italy because I'll be going to the Isokinetic conference next year, which I'm excited about. So I may make a pit stop to do that. That's your hometown city, but you have lived in Santa Monica, California. You did a fellowship there. How would you compare your impression of Americans having been in America? You studied for a year, to what you thought growing up as a kid?
Well, it's a little bit more complicated than this because I travel all over the world to update. I've been a little bit everywhere. In terms of the main differences between Italy and US, wherever US, because I've been in many places. So in Italy, we have these small cities, rich of culture, but with little streets. And we do have some fixed architecture inside the city centers, for example. Whereas in the vast majority of United States cities, you don't have this limit. So basically there is space for huge highways.
Yeah.
And this is the first stuff that you get immediately. When I get to the US for the first time, I was 12.
Oh.
And this is the first time that you get, for sure.
Uh-huh.
And then there are all the subtle differences in terms of culture, but this change a lot between East Coast and West Coast, and also different cities in California. You have a different point of views, but for sure people are open-minded and are straight to the point. What I learned to do in the United States is to go straight to the point. And this is one of your quality. In terms of Italian, we are the sons and daughters of Leonardo da Vinci. So we pay attention to details. We like the arts. We like the beauty, and then there is also a little bit of dolce vita. So we like it well.
Okay.
Yeah, we like beautiful things. In Italy, we like beautiful things.
Yeah. Well, it's clear that your passion for soccer went beyond the field with all that you do now. How did you come to realize that you wanted to become a doctor and specifically work? I mean, I know you do a lot with knees, but it seems like a lot of your research, though, that I've seen is really around soccer. How did you come to realize that passion?
So I work in the company that was founded by my father. Okay, so the engagement and the name of the company is Isokinetic Group. The engagement with Isokinetic for me was very early in life, probably when I was 7, 8, 9, 10 years old. And I started doing the first stuff in the company when I was 12, 13. I was the helper of the helper of the helper in home rehabilitation.
Okay, you have to explain that to me. I don't know what the helper of the helper, what does that mean?
It means that you are a sort of slave level, okay? So you basically, I was bringing the balls, okay? And the cones, all the football stuff for home rehabilitation, because we have been doing home rehabilitation for our patients since the very beginning. So when early 2000s or around 2000, I started doing this. Rehabilitation was really, really huge in our centers, and in Bologna especially. So really, I was a slave level because we had the head of rehabilitation, then a couple of trainers that are our rehab specialists on the field, then some interns, and then there was Francesco. This was the beginning. So just to let you know that my engagement with sports medicine was very early in life. And then I could decide to study whatever, but I follow a little bit my attitude. My attitude is absolutely cultural and scientific. And also I follow this a strategy, because in order to have the vision to go forward, to do the best for our patients, the best for our players, I needed to study medicine. And so I studied medicine, and I remember very well that for me was a very easy decision, not a pretty straightforward. My father is a doctor, is a physical medicine and rehabilitation specialist. My mother is an architect, so I try to blend everything that I have inside my genes.
Yeah.
And so I like arts. You see now, because we are in video, you see my office.
Yeah.
Okay? So there is a little bit of art also in my office, but for sure I have a scientific vision. So it was easy for me to decide medicine. And the School of Medicine in Bologna is one of the top school in Italy. So no reason why to move to another place. But then I started visiting countries and having experiences in the field of sports medicine very early during the medical school. So my medical school was not a standard medical school, and as well I was working in the company with various duties up to get inside our education and research department.
Wow, interesting. So it sounds like you just came to love it, but so you tell me as a kid, there weren't times where you just did not want to go into the clinic and do the work, help out. You never had moments like that. You always enjoyed it.
Honestly, no. I've never had these moments, and it was completely natural for me. Completely natural.
Completely natural.
Yes, it is very difficult to explain, because you need to be in my shoes to understand.
I mean, I can't imagine being a kid and doing all that at such a young age.
Yeah, it's not easy.
Yeah,
it's not the easiest stuff ever, but it was completely natural for me. So
I see.
It is mainly related to holding the pressure, holding the expectations, and then hard work to meet them.
Yeah. Like, you're a clinician, you're a researcher, you also speak, do all this engagement. What is a day like for you? Because I know you're still at Isokinetic in Bologna, right? I'll never get that right. But what's a day like for you? Because I'm still trying to piece together. Do you see athletes all the time? Is there a certain part of the day where you are doing the research? What is it like?
So first of all, I work in Bologna, because in Bologna there are our headquarters also. So we have the clinic that is 100 meters from my office, but I'm in a different building. In Bologna, we have our general direction and our education and research department. So we manage all the big clinics of the network. We have 8 clinics, 7 in Italy and 1 in London, from the headquarters. So the conference office is over there. So we have everything here. So my daytime, well, it varies because I travel a lot. And I restarted traveling now, thanks God. Now we restart a little bit the travels. In a normal day of office, I start pretty early, but not very early. So between 8 and 9. And basically, I stay in my office for the vast majority of the time, because now my activity shifts from a clinical and scientific to scientific and managing activity. So basically, I oversee all the activity of our education and research department. That means updates, that means education, that means scientific activity, talking with people, managing human resources, and creating an internal and an external value. Really, I stopped few months ago, just 1 month and a half ago to see patients, because I was carrying on an activity on movement analysis testing, because this is something that I have to develop personally, and I'm an expert in terms of clinical application inside our group. And so this is something that I was carrying on, but managing all the activities of an education and research department is not kind of dealing also with a real clinical activity, because or you do one stuff or you do another one. And then my day finished at well, I don't know, 9, 10 or whatever.
9, 10 p.m.
Yeah. So
okay.
Full of different stuff. I have fun, but we hard work over there. So
yeah. So you said just a month ago you kind of shifted away from actually seeing patients to do completely more of kind of the educational, the research component. But I'm curious, when you first started to do your research, like, were you practicing first just treating athletes before you started to do the research, or did you literally, as soon as you finished that fellowship, you went straight into both?
When I was doing the residency, I worked with a lot of patients. And because you have to imagine that my residency was a little bit residency, a little bit of isokinetic. So I've seen everything in terms of the system by a clinician point of view. And the fellowship at the end was also here abroad, also with the family, because my son was 6 months when we went to CA, to California last time, and it was wonderful. It was great. And our kind of research activities are always related to to practice translation, to translation into practice, because we have all the clinics. So we can do research that apply the same day or the day after to the next patient. This is something that we like to do. We don't publish paper for the sake of publishing. We are not a university. So we do it for our patients at the end. So it is at the end for us, it's just another way of treating better our patients, because throughout all our research activities, we refine our protocols. And this is key. And it's also key to engage your people, because we have a lot of internal meetings with also a bottom-up approach, not just an up-down approach. So we do this.
I see. Okay. So you said you do the research for your patients. When you were up and coming, what were some great advice that you got when it came to research? You know, sometimes the research doesn't go as expected. What advice did you get?
Well, first of all, there needs to be a clear hypothesis. When you do something, you need to have something in mind that should be translatable, that you can translate into practice. If it is something that it cannot be translated, for me, there is no reason for a clinician, not for a basic scientist, but for a clinician to do it. So the first really to have an hypothesis. For example, I think that we think as a group that neuromuscular training may help in preventing second ACL injury, in reducing the second ACL injury to happen. Okay, you create a design and you really think all the available evidence, a structure of your study to answer that question. The question can be yes or not, or we don't know, but generally it's a yes or not. And then you have to be honest and accept the result. That's it. This is the first question. And the second question is follow your passion. So follow really your passion. We started to doing video analysis studies because I have myself a real passion in video analysis. I like video analysis. And then from a passion of one man, this is a passion of a group of people that is working day and night to see video and systematically analyze injuries to understand them better and trying to really afterwards treat them better. Because just an example, one of the findings that was more popular about one of our first video analysis studies on ACL in football was that the vast majority of the ACL injuries happen in the first minutes and not in the last minute of the game. I mean, if you ask anybody in the world, you ask this question and say, oh, no, it's in the last part.
Yeah.
It's exactly the opposite. So sometimes we don't see the reality because you have to check your opinions because at the very end, we all have opinions. But opinions are just opinions if they are not linked with facts, okay, with data. So we have to back up on this. When you know this, you can try to really understand why you are doing some stuff. And so this is just an example. Every piece of information of a study can be translated. You have to find the translation. There is no sense to publish the paper for the sake of publishing.
Yeah, that brings me to the point, because the Isokinetic Center, I imagine you all have
the high-tech equipment that not all clinics have, like say to ortho outpatient clinic. Regarding to functional assessment, assessing movement, what are some strategies even a clinician could use that is not necessarily high-tech, the devices that maybe Premier League clubs have? How can they try to assess the functional movement of an athlete using maybe some of the most basic material?
Sometimes I have to make a call. Sometimes it's not me, but we have to make a call collectively. And we don't have, in many cases, the super high tech, the top of the top, because this is not really transferable into practice.
Right.
So, for example, I do not think, and this is our opinion, that 3D biomechanics is affordable for every patient in the assessment after injury in every clinic. For us, it's not affordable. So we decided to apply a solution that is really a 2D video analysis system with a little bit of tech for sure, but it's not as complicated as one can think. In terms of video analysis, there are many available softwares and many available tests that you can use also by using just your iPhone or your iPad. So the iPhone and the iPad cameras with the slow motion modality are fantastic. So you have to put some culture inside. So you have to update yourself to read a couple of correct papers, and then just apply what you have learned throughout the analysis. You can check many stuff.
Okay.
Sometimes the tool is not important, but it's the knowledge of the phenomenon that is important. If you don't know why you see something, try to Google it. Try to go on PubMed and to try to find the solution, okay? And this happens many, many times also to ourselves. At the very beginning, when we started adopting video analysis, we are not sure about many stuff. Yeah. And then you learn a piece, then you learn another piece, then another piece, and you refine. And every day, and we are still in this process. Yeah. So really, when you study so many years and medicine and the residency and the fellowship, the studies never ends. You are always refining something that is already good, but you aim to excellence, you aim to perfection.
Yeah.
So what we aim is to try to be perfect. And sometimes it's not possible. Sometimes it is possible.
Yeah. You brought up on a good point. You talked about how clinicians can really use a 2D, whether that's getting two angles, using their iPhone, getting a frontal or sagittal. And you said it's not so much about the tool, but I imagine that there is kind of like a vision, like an eye that someone needs to have to be able to discern this. So you think maybe looking at the research and then going back to their footage that they've captured and slowing things down. Are there any other things that have helped you kind of assess the movement and really pick out those specific deficiencies, whether that's replaying it over and over? What has helped you?
First of all, a trick is for sure the slow motion. So the iometer doesn't work very well. But if you have a slow motion video, a really slow motion, for this kind of stuff, iPhones and iPads are perfect. If you don't have access to other options, and then you see many times the video, but just seeing the video doesn't work if it is not backed up with knowledge, because you have to know what you are looking for. So just an example. So being a little bit also technical to give some information. If you check a monopodalic movement in an ACL reconstruction athlete, the first stuff that you need to look is not the frontal plane, is the lateral plane, so the sagittal plane. Because many times when you go monopodalic, these players have a so-called deficit in shock absorption. Or this is, as my teacher, Christopher Powers in California, called it. The shock absorption is basically a lack of knee flexion. So you have this knee that is not really flexed. And then what happened is a compensation on the lateral plane with the trunk. So basically they don't flex the knee, but they flex the trunk. because they bring forward the center of mass, and this reduce really the knee external moment. So reduce the knee moment, reduce the knee loading. So they deload the knee, loading the trunk and the hip, and this is the first compensation that you see monopodalically mostly every time that rehabilitation is not done properly. And this is the first stuff that you can see. When you see this, you suspect a quad deficiencies that can be just a quadricep deficiency or a quadricep strength deficit. In vast majority is a huge quadricep strength deficit. When you see something like that, you bring them in the gym and you work on the quad. That's it. No fancy stuff. Quadricep strengthening. This is the first thing. Then you can look at the frontal plane. And the frontal plane, you don't have to limit your vision to the knee valgus. Of course, all the different factors related to a dynamic knee valgus loading can be viewed, can be objectivized, and it is absolutely useful. But you have to look also the pelvis and the trunk. This is critically important in our experience because many patients compensate again with the trunk and the pelvis. Or what happens? They don't bend on the sagittal plane with the knee, and something has to bend. And so they bend the trunk. They don't bend the trunk just forward, but they tilted the trunk laterally also. So this is something that we call the knee avoidance. So try to be really selective on the stuff that you are looking for. Apart this approach that I explained you, there are many different tests available in the literature. You can check the work of Greg Meyer, for sure, on the tack jump assessment, the work of Darren Padua on the LESS score, that is a score to score the drop vertical jump. But then there are also many other papers that are mostly related to the work of Hewitt, Meyer, Ford, and all these kind of research, US research teams.
Okay. Well, take me back to the time when you first started practicing, and I imagine you didn't have as much knowledge as you have now. How did you make those connections with people in your field? I know that you have been involved with Isokinetic, but you've made a connection with people all over the world, it seems.
First of all, again, you have to follow your passions. So you have to follow also your instinct. If your heart tells you, so your instinct, your drive, your internal drive tells you that a certain stuff is interesting, go for it. Go for it. So you have to try to learn what you think it is important, because generally it is important. So you have to be really selective. Then you have to be patient. It's like applying a targeted neuromuscular training. So it happens because of neuroplasticity. And it follows different phases. Learning is like this. You have to be patient. You have really to be patient. And then you have to understand how can you impact on the world health. So you impact on your patients. I don't know, maybe you have 20 patients a day. Well, it's a good impact. Then maybe you impact on that patient, and then you decide to bring a communication, an abstract about your experience to a conference. Then maybe you communicate to your patient, but then you bring also something else, and maybe you inspire another one that was you 5 years ago. Then maybe you decide to link with the local university and try to write a paper, and so you arrive to more people, and so on. So what I realized coming back from US in 2013 was, I remember very well, I was on the airplane. So when you are on the airplane, you fly very high. I like to think about life when I'm flying intercontinental. and basically, I really thought that collectively, we were impacting on the world health. Maybe a little piece, but yes, because one paper after a paper, one conference after one conference after the other conference, one talk like the one that we are having now. This is worth it, because even if I'm able to inspire one person today, this is enough.
Yeah.
So you got with them more than
yeah.
you have to see what are your attitudes. Maybe you have attitudes just for clinic. Okay, yeah, it's great. It's absolutely great. If you have an attitude just for science, great. I don't think that there is something that is more important than the other. And okay, so
all in all, it sounds like your passions and your commitment to really keep going has really paved the way with all that you do today. But it seems like you have a love for ACL. How did that come about?
I don't know. The ACL is ACL. So the ACL is my favorite body part.
Why though? There has to, you just decided ACL? I mean, there's MCL, there's meniscus, there's all these other things. Why ACL? There has to be something.
Well, a number of stuff. First of all, as a clinic, we treat many ACLs. And then the first two patients of isokinetic back in 1986-87 were ACL reconstruction patients. So the first patient that you see, if you go on our website, is the isokinetic machine with my father next to them, ACL. So just to let you know, in 1992, we had a casuistics of thousands of ACL. Then when I approached our world scientifically and clinically, around mid-medical school, because before I was more in practice, but I didn't have the complete picture. We were doing a lot of studies on cartilage.
On what?
On cartilage. Cartilage. Very interesting topic, but I didn't fell completely in love with cartilage. At a certain point, I just decided to do my thesis project for the medical school on ACL reconstruction. And throughout all the experience that I had later on, and I visited many places. So I've been with Lindsay and MacLeod, I've been in my clinic, I've been, of course, in LA with Bert Mandelbaum, with Christopher Powers, and in many other places were always linked to the ACL. And then I met the king of ACL, Freddie Fu.
Oh, Freddie Fu. Yeah.
And Freddie was very special, very, very special. Freddie was a long-term friend of the Isokinetic family, but I met him in 2016. And this was in an Isokinetic conference, and I had a talk in our conference. This was the first talk in our plenary sessions, so I was also a little bit, it was the very first in the plenary.
Yeah.
And after me, there was Freddie Fu. So when you speak before Freddie Fu and you are, it is something, and you are around 27 years old, as a young clinician, I was a resident at the time, but it is something.
Yeah.
And I presented our data for the first time on the 1001 ACL study, that is basically an outcome studies with the various predictors of return to play. And then I attracted maybe Freddie with my presentation. I honestly don't know.
Wow.
But after that, he engaged me, and it was incredible.
And when you say he engaged you, what about him made you feel engaged? Is there something that he maybe said or?
Well, with Freddie was magic. Freddie is about magic, because he paid attention to relationship between human beings. So he was a king, but very, very friendly, very, very down-earthed with you. He was striving for knowledge, and always very kind with me, very kind with my family, very kind with my son, but striving for excellence. And you could see this. And there was an incredible balance. Freddie was the king, not just on ACL, but also on soft skills. So really incredible in in this human approach. And after meeting Freddie, then really I completely fell in love with this. So after meeting Freddie, there was like a wedding between myself and this
and the ACL.
Yeah,
Probably,
absolutely.
you fell more. Hopefully, you didn't fall more in love with your ACL than your family, right?
No.
Okay, good. I just have to make sure.
No. This is just work. The real love is another one. It is proper family, of course. But working wise, really, I mean, this connection with Freddie was very important. Very important for me. And obviously, when he passed away, it was hard, very hard. Very hard, because we were really strongly linked. I think that his legacy, because he inspired thousands of people, like thousands of young clinicians, and was very inclusive, very inclusive for absolutely modern man in this. I think his legacy will be absolutely forever.
I would agree with you. Having only, like, I've read things that he's written, but I really didn't see him for the first time until I watched one of the Isokinetic things with Ibrahimovic. He talked about his whole surgery. And, watching that, I just thought, man, like, he just seems like he has the best interest, the way that he spoke. So I never had the opportunity to meet him, but it definitely seems like his impact in medicine is worldwide for sure. What's one thing that that you take away from his personality that you hope to continue to like inspire maybe your patients, the people that you interact with?
The main take is be always kind. There is no reason not to be kind with anyone. And no matter what, then when there is engagement, because if you give yourself, so your values, to a young clinician that you maybe is treated in a rude way in his, in his university, in his department, I mean, you can change his life with 1 or 2 meetings. That's it.
Yeah.
That's it.
And I think sometimes some early clinicians feel like they don't know enough and they have to keep striving to read. In the midst of it, it's really to realize like we're still interacting with people. This thing that you just told me, is this something that you always felt like you had a grasp of? Or during your early career, did you at times feel like you were always reading, that you weren't really stopping just to embrace kind of the interaction that you have with others?
Well, this is a very important point. When you are young, and obviously nobody is perfect, so I'm not perfect. I make mistakes. When you are young, you strive for knowledge. You want to have technical knowledge. But the treating patients many times is not about technical knowledge. It's about knowing the process. So the process is much more important, and the process is about relationship also. In medicine, and this is a very important, not trick, but general principle. We don't have to be vertical. So, for example, Francesco does a very bad movement analysis testing or a very good movement analysis testing, but being horizontal. So the patient completely a perfect, an almost perfect functional recovery process with many different interactions with different individuals, but with the team that is taking care about him or about her. So this is very important. At the very beginning, it is normal that you just look for knowledge, technical, little technical pearls. They can make the difference in one interaction, but they don't give you this attention to the whole process. And unfortunately, this is something that it can be strengthened in terms of our education as clinicians, as physicians. We are more taught about how to consult on someone. That is important. I'm not stating this is not important, but there is also the other part of the process and relationship.
Yeah. I want to go back to ACL because, we talk about, well, in medicine, we talk about trying to prevent another injury, but making sure they return back safely. When you have an athlete that you all feel that, they've met their milestones, they've kind of checked off those criteria that you all look at, and it's past maybe 2 years and they have a second ACL injury and they're in your office, what is a conversation that you have with those patients?
Well, of course, these are the most difficult patients. First of all, we are sorry. We are sorry. We are deeply sorry because you have to think that, and you are a clinician, so you know this. When a patient stay with you for months, really, starts to be part of the family. Yeah? Or 1 month, 2 months, 3 months, 4 months, 5 months, 6 months, 7 months, and then champagne when you get back to play. Then after 2 years, contralateral. But it is something that you should prepare before. You have to be completely honest with your patient. So this is very important. Do not be afraid to be honest with your patients.
And what does that look like for you?
So this is very important. And so you have to prepare for this moment that will happen at the beginning. So at the beginning, if you have a 15 years old boy or girl that had an ACL injury, non-contact ACL injury, maybe they have also a positive family history for ACL, you have to speak probably in this case to the family and state very clearly the chance to have a second ACL injury within 2 years are around 30-35%. 14, 16 years old, so really teenager, very, very young. Because these are the numbers. We can reduce this percentage applying high quality, evidence-based rehabilitation. But this percentage will not go to zero. It is difficult to say because we don't have still data, just opinions. This is difficult to say what it is, but in our system is not higher than 10-15%. So you reduce as much as you can, but it's not zero. Is not impossible. Zero is not possible, and so you have to prepare that because it is what it is. There is a high risk. When you have high risk individuals, you reduce the risk, but you consult. So being really a doctor is also about being honest with your patients. I remember a patient of ours in London, Achilles tendon rupture, that told us in an interview after the return to the team that the most important stuff for him is that these guys, so ourselves, we were incredibly honest with him. Mm-hmm. So sometimes you have to say to the patient, no, this is not the way. So you want to be back because I have to be honest. You are not ready. Mm-hmm. So I have to be honest. The risk is 20%. It is what it is. If you don't speak about it at the beginning, then this talk 2 years later in the clinical room is much more difficult.
Yeah.
So you have to prepare it, and then you have to accept the reality. And sometimes the reality is brutal because we want 0, but 0% second ACL is unfortunately is not possible. So
yeah.
Still.
And for athletes who have to recover from a second ACL injury, oftentimes, as clinicians, we have to be sure that their fear avoidance, it's not high. What strategies do you use to help athletes get over that? I mean, I'm sure they have psychologists, but are there things that you may tell an athlete to kind of get through that mind of like, I don't want to injure this again?
So tricky because the second time is really different. The second time is not easier or more difficult. It's just different. On one side, you have someone that has already passed through it, so they are more prepared to be also compliant to the indication. One of the most important stuff in rehabilitation is compliance, is adherence to the suggestions. So we are really fixed about this. That means the correct number of sessions and the correct frequency of sessions, because this makes a difference. Why a professional player? Why professional players get back in 100% of cases? Of course, because this is their job, okay? But also because they are treated with a lot of volume. Five times in the morning a week, 5 times in the afternoon, and the Saturday. 11 sessions of rehabilitation. This is what we do for professional athletes. A recreational or competitive recreational athlete is 2 to 3 sessions a week. Maybe you can stretch to 5, but that's it. Okay, so volume and frequency are very important, because that means that the frequency of stimuli. So how to deal with a devastated person after a second ACL injury in rehabilitation? Of course, we can have a psychologist, but in first line, we can be the team of caregiver. We always speak about the team around the patient, so the patient triangle we call in Isokinetic, has to be a little bit a team of mini psychologists. Okay, this is crucially important. And then you push on the aspects of rehabilitation that may really create the drive to be back and to feel back. And off-field rehabilitation in this extent is the most important one. So when we check really the ACL-RSI throughout rehabilitation, you see that when they are in our green rooms, that are the environment for movement analysis testing and neuromuscular training, the ACL-RSI stays the same. The ACL-RSI jump high when you do off-field rehabilitation. And off-field rehabilitation is really key. So the number one feature, the most important trick that I can give you is to complete rehabilitation.
And I was going to get to that, because sure, we have professional athletes that are consistent with the rehab, but why does it seem so difficult for people to stick with the rehab? Do you think that it's maybe a not a miscommunication, but maybe a communication thing that clinicians can be better at stating up front? Why do you think that's still the case? Because sometimes, even for me, I have some patients that, they'll do it, but they feel great, they're in their sport, and then they're like, oh, I don't need to do it anymore. Why is that?
Well, this is the question. So there are multiple barriers, of course. So we can speak if we go analytical, there are several barriers. First of all, there is an economic barrier. Okay, so unfortunately, some patients cannot afford to cannot afford to finish the rehabilitation. Some other patients decide not to put money into finishing rehabilitation. This is another type of patients. This patient can be convinced that rehabilitation is useful for their health, but then it's a patient decision at the end. And then there is but I think that the money barrier is not, the economic barrier is not the first one. The first one is a time barrier, because really rehabilitation is time consuming. It's really time consuming and energy consuming, because sometimes it's boring. Rehabilitation sometimes is boring. And this is not. And so we shouldn't be boring. Absolutely. Because boring patient means that the patient will stop. So we have to change the environment, we have to change the stimuli, we have to change the exercise, we have to use the feedback, we have to implement something new. when to use technologies, we need to do that in order to let them recover completely, both physiologically and psychologically. So really, sometimes after injury, you can be fitter than before. Absolutely. By many points of views. And this is something that we really push in Isokinetic, and we teach our people to try to reach that with patients. Why? Because if you got injured, maybe there were some factors that related to this injury. Maybe you were a little bit overweight, maybe you were not moving really well, maybe you were not so strong in some muscle groups, maybe you had some imbalance, so you can be more fit, working on the aerobic thresholds, for example. Maybe you can move well, better, working with neuromuscular training, and you can be stronger, working absolutely in the gym. And even you can then, for example, if you have a young patient, young ACL patient, a football injury, a pressing injury, these injuries are related also to a very aggressive playing style sometimes. Mm-hmm. If we understand this, we let him or her think very carefully about it. The playing style sometimes is very important, is a trait, but can be a little modified. So, for example, you have to think a little bit more about being so aggressive at the beginning of the match. If you cannot reach a ball, you cannot reach a ball. No way. Mm-hmm. But risk, because many times in the pressing ACL injuries, there is this component of really aggressive playing style. So you can work on factors to get even fitter than before. But you have really to complete everything. You have to accept that it's a long process. It is, because it is a long process. Mm-hmm. It is a little bit like carrying a baby. It's long.
I don't know that process yet, but it seems pretty long. You have one kid on your hand, so yeah, I'm sure you've seen the process. My last question for you is just for future, whether it's doctors, clinicians, what is the single most important advice that you would tell someone who wants to specifically work with athletes at a high level?
A professional athlete is a different patient. It's just different. I suggest you to see Zlatan Ibrahimovic video for UPMC on when he get back from the ACL. There was also in our first virtual summit on ACL injuries. I will use his words. So these are Zlatan words. Mm-hmm. I define myself a normal animal, a normal guy, a normal man. But when I get inside the field, I'm a different animal. Okay. So this is powerful, and it is the reality. So if you, of course, you can treat a non-professional athlete as a professional athlete, but you have to consider all the contextual factors of a professional athlete. And there are many contextual factors, but the first one is that really they are warriors. And you can have, it's the same for men or women, doesn't change anything. So they are warriors. This is their job. And also they have, and you have to accept this, they have risky behaviors, because performance is everything for a professional athlete. Sustainable performance for sure, and this is something that I'm pushing on every day. Sustainable performance, not performance at all costs, but performance for a professional athlete is super important. Is the number one stuff. They don't ask you to prevent or reduce a secondary injury. They ask you to return to play as soon as possible. Yeah. That's it. And then you have to balance the performance injury risk conflict. And a few years ago, I didn't get that, but now yes. And you have to embrace this. The performance injury risk conflict is the conflict between the principle of health medicine and the principle of competitive sports. that are not getting very well together.
Yeah.
So there is a conflict, and you have to embrace this conflict, and this is the work of sports medicine. So if you want to work with professional athletes, you need to embrace and to accept the performance injury risk conflict. That's it.
Yeah, be okay having those conversations with the athletes too.
Yes. Absolutely okay, because this is life. Maybe it's ideal, maybe not, but it is. It is what it is.
Well, that was all great stuff. I'm going to see you at the Isokinetic next year. Am I right?
Yeah, absolutely, in Lyon. So yeah, you told me. So we are happy to have you, and we hope that you are gonna have a nice experience.
No summer plans in 2022 and wanting to expand your soccer medicine knowledge? Be sure to head over to the Isokinetic Medical Group website to check out their football medicine conference in Lyon, France in 2022. Well, hope you enjoyed this episode. Be sure to rate, subscribe, and give me your thoughts.